Hello everyone, I am Dr. Parag Bhadagat. I am a pediatric cardiologist working in Mumbai at Sujit Heart Clinic. Today I wish to discuss role of pulse oximetry in diagnosis of or in suspicion of critical congenital heart diseases in neonate. Let's understand significance of the same. If we go by Indian data, in India every year close to 2,60,000 babies are born with congenital heart disease, which may be minor or severe or critical one. Congenital heart disease accounts to 1% of all newborns. Now, critical congenital heart disease accounts for 25 to 30%. So the number is around 75,000 to 80,000 babies have critical heart diseases. And if these babies are not attended in time, they are at risk of severe complication, morbidity and mortality. So they need immediate medical help and attention. So what are these critical congenital heart defects? A major group of them is duct-dependent systemic lesion, where PDA is required for circulation of blood in body. And these include interrupted aortic arch, critical coarctation of aorta, hypoplastic left heart syndrome, and critical aortic stenosis. Other group includes duct-dependent or PDA-dependent pulmonary circulation. This includes pulmonary atresia of various forms, various congenital heart diseases associated with pulmonary stenosis or atresia, that include Tetrology of Fallot, double aortic right ventricle, congenital corrected transposition of great arteries. Any of these diseases, if associated with severe pulmonary stenosis or atresia, again they form a critical congenital heart defect. Again, isolated critical valvular pulmonary stenosis is another subset. Other includes total anomalous pulmonary venous connection, transposition of great arteries, and complex cyanotic heart disease, which include univentricular heart, Tetrology of Fallot with DORV, or functional heart. Now, once baby is born and is admitted in nursery or is with the parents, and is generally discharged at 24 hours after delivery. So before discharge at 24 hours, thus pulse oximetry screening is recommended. It is usually done at two places, right hand and right leg, or you can do it any hand and any leg, but hand and leg is mandatory. If saturation of both hand and leg is more than 95% and difference between two is less than 3%, then it is a good result. It's a pass, no further action is required. If saturation is less than 90% in any of the place, in either hand or leg, then it is a fail. Further evaluation is required. If saturation is between 90 to 94% and difference is more than 3% in the right hand and right leg saturation, then we need to repeat it 2 more times at 1 hour interval. If any of time the saturation is more than 95% with less than 3% difference, it's a pass, don't require further intervention. But even at 2 more occasions, it remains less than 95% and difference is more than 3%, then it's a fail. So this is just a protocol as given by American Academy of Pediatrics. Other important part of pulse oximetry is palpation of lower limb pulses. If they are palpable, it rules out any major aortic arch anomalies like coarctation of aorta, aortic arch interruption. If lower limb pulses are weak or they are not palpable in a newborn, it requires urgent evaluation and maybe a 2D echocardiography. Now, things are a little different for a premature baby who is on the NICU. It is done in 2 stages. First stage is within 24 to 48 hours of birth. Even if saturation is less than 95% and difference is less than 3%, and it fits with the clinical picture of the baby, if baby has got respiratory distress syndrome or meconium aspiration or some other condition, then it's given as a conditional pass. If saturation between upper and lower limb difference is more than 4%, 3 times 1 up hour difference, it is a fail. Or if saturation is less than 95% and it doesn't fit with clinical picture of the baby, then it is again a fail. Now stage 2 is once baby is weaned off from oxygen. It is same as repeating American Academy of Pediatric protocol as I explained before. There are two more steps. If a baby cannot be weaned off from oxygen, if he is oxygen dependent to maintain saturation, then it is again in a fail. Or oxygen remains below 90% after taking out oxygen supply, then it is again a fail. So saturation less than 90% or dependency on oxygen is again a fail test. So if test fail, the baby needs a thorough physical examination to rule out any other cause of desaturation. And this baby need further evaluation by a pediatric cardiologist and a 2D echocardiography. These tests are fairly sensitive and specific. A small time given to pulse oximetry can save a lot of babies and give them a better life. Thank you for your valuable time.